Good morning, dear students. This is Dr. Walid Dars. We are going to talk about the important topic which is termed hypersensitivity. By the end of this lecture, you'll be able to identify the types of hypersensitivity and explain the mechanisms of different types. So regarding our lecture outline, we'll discuss the hypersensitivity types, mechanism, diagnosis, and treatment. This will be for type 1. While type 2, type 3, and type 4 will discuss the mechanism, okay, and the types or examples of these types. At the end of this lecture, we will have an important topic, which is the link between hypersensitivity and autoimmunity. Okay, it's a very, very important topic. In hypersensitivity, what is the meaning of hypersensitivity? Hypersensitivity is undesirable or damaging reaction produced by our immune system. Okay. We have two main classes, which is antibody-mediated or rapid reaction, hypersensitivity, and the other arm is cell-mediated or delayed. The antibody-mediated, we have type 1, type 2, type 3. Type 1 from half an hour to an hour after exposure to the antigen or allergen. Type 2 up to 8 hours. Type 3 also up to 8 hours. While type 4, it's up to 72 hours from the time of exposure. Okay? In the rapid reaction, or type 1, type 2, and type 3, it's very important to know the type of the antigen or allergen, the antibody produced, okay, the mechanism, and the types or examples of each of these three types, type 1, type 2, and type 3, which is the rapid reaction or antibody-mediated reaction. Let's start with type 1, which is the commonest one, which is termed also anaphylactic reaction. We have allergens, which induce allergy, maybe inhalant, like the pollen grains, the fungal allergen. It may be injectants, like drugs, okay. Maybe contact, like antiseptic sprays, okay. Type 1 is termed immediate, or sometimes we term it anaphylactic reaction. May occur in the skin, like urticaria and eczema, just redness and swelling in the skin. In the eye, conjunctivitis, inflammation and redness of the eye. Nasopharynx, like rhinitis and rhinorrhea, there is a running nose. Maybe in bronchopulmonary tissue, this is asthma, okay? Bronchial asthma is a type 1 hypersensitivity reaction. Maybe gastrointestinal tract, like gastroenteritis. Maybe fatal, like the anaphylactic shock, in case of penicillin hypersensitivity. What is the mechanism? Let's understand it with each other. At first, we are exposed to allergen. In the normal immune response, okay, it will be presented by the antigen-presenting cell to T helper cell, then activation of B cell to release IgM in the primary immune response and IgG in the secondary immune response. But here it is different. The allergic person, after activation of T helper cell, it will activate the B cell by interleukin 4 and 5 to release what? Develop into plasma cell and release IgE. Okay? The IgE is fixed by its FC region on the surface of mast cell and basophils by attachment to the FC receptor. This is not a problem, but the problem here, after the re-exposure, the allergen will cross-link to adjacent IgE antibody on the surface of what? The mast cell and the basophils. That will lead to what? Calcium influx inside the basophil and mast cell with the release of the mediators, which are histamine, leukotrienes, and the others. And these mediators will lead to the development of what? The manifestations of allergy. Again, we have first exposure, the allergen will activate the T helper cell and B cell to develop into plasma cell, and the plasma cell will release IgE. The IgE will be fixed on the surface of mast cell and basophils, okay? Then on re-exposure, cross-linkage of adjacent IgE present on the surface of mast cell or basophils will lead to what? Calcium influx inside the cell and the release of mediators like histamine and leukotrienes. And these mediators will lead to the development of manifestation. Okay. This is another photo for the allergen and the release of mediators. And these are the mediators causing rash, wheezing, vomiting, and wheezing here the bronchial asthma due to bronchoconstriction. So what are the diagnostic tests for immediate hypersensitivity? We have first skin prick or intradermal test. I have a person who is suffering from hypersensitivity or type 1 hypersensitivity or allergic for specific material, for example pollen or certain food like egg or banana, mango, and so on. I have prepared in the lab this allergen in a phosphate buffer saline solution. Then by the back of the scalp, by the way, just fine scratching on the skin, the forearm like this. Then after scratching, I put a drop for each one of these allergens. A drop for example, pollen, a drop for mango, banana, milk, and so on. If the person is allergic for this type, there will be a swelling like this one. The skin is red, itchy, and small swelling like this photo. If he is not allergic, no change will occur in the site of application of the allergen. Okay, this is a simple one, but the limitation here is that I can only examine a limited amount or limited number of allergen. The other one is the prick test or a skin patch test. This gives us the advantage of examining different types of allergen on the same time. Many numbers like 1, 2, 3, 4, 5, this 10, 20, 30, 40, 50, 60, 70, 80 patches. Each one of these contain specific allergen. Okay, it is applied, scratched on the skin, then removed. Okay, to see whether there in its side there is a redness and swelling like this or not. The other one is the measuring of total IgE, okay, and the specific IgE for each allergen inside the serum of the patient by ELISA technique. How can I treat this type, the anaphylactic type or the immediate type or type 1 hypersensitivity? Avoidance of exposure, the first one. Symptomatic treatment is the second one. And third one is the immune therapy. And this is the new one. The first one, avoidance of exposure. For example, we have what's called dust mite allergen, present in the matrices and pillow. In this situation, we should cover the matrices and pillow with dust mite resistance cover. They are present and sealed. For fungal allergen, okay, like the spores of fungi, we should remove indoor plants, which remove the mold growth. Also, drying or removing any wet carpet present, because it allows the growth and production of the spore by the fungi. Symptomatic. I'm just treating the symptoms here. We can give the person antihistaminic because the histamine is a very, very important mediator. Can block the antihistamines block the histamine receptors. Chromoline sodium, it will prevent the calcium influx, so it will prevent the mast cell degranulation and the release of mediators. We can also use leukotrienes receptor blockers or inhibitors of cyclooxygenase. This enzyme is required for the production of leukotrienes. Okay, this will help in treating the late onset allergic symptoms like bronchoconstrictions, okay, which is mediated by leukotrienes. Last one is bronchodilators, the inhalants. In case also in bronchial asthma and where there is a bronchoconstriction, it provides a symptomatic relief of the shortness of breathing. But this will be for short term, okay? So what is the effective therapy? The immune therapy. It is effective, but it takes a long time, okay? Even years. I have met to the person what's called the allergic skin test or the prick test and so on, and have determined the types of allergens. Okay, here we use a gradually increasing dose of allergen extract at regular interval over a period of years. So it is very long in time, starting with a very low dose, then increasing the dose. This will lead to what? Tolerance, development of tolerance to this allergen. So there will be no immune response against it. I can administer the allergen by injection, drop, okay, or tablets under the tongue, sublingual. What happens here? The first is the development of regulatory T cells, which will stop the production of IgE. As you know, Treg cell, regulatory cells, inhibit B cell, inhibit T cell, and so on. So it will inhibit the production, stop the production of IgE. Moreover, the B cell start to what? To produce allergen-specific IgG4 antibodies instead of what? IgE. So there is adaptation for what? From B cell to the allergen. Return to normal production of IgG instead of IgE. IgG4 will block what? Block the allergen on subsequent exposure and prevent it from attachment to the IgE fixed on the mast cell. This figure is very good one for this. On the first year of treatment, okay, recurrent exposure to the allergen will lead to what? Still we have the IgE high. On the second and third year, the B cells start to produce IgG4 instead of IgE, okay, with the reduction of IgE production. The IgG4 will block the allergen, attached to allergen, preventing it from attachment to the mast cell, or the IgE present on the surface of mast cell and basophils. Subsequent years, 2 years follow-up, for example, Treg cell will develop and inhibit both mast cell, T helper 2 for production of IgE, and also there will lead to what? Complete disappearance of what? IgE, and the antibody present on re-exposure to this allergen will be IgG4 only. So we have increase in the IgG4 instead of IgE, and the Treg cell will inhibit the production of the activation of mast cell, the activation of T helper 2 cell, which leads to activation of B cell producing the IgE. We have finished type 1. Let's move to type 2 hypersensitivity. It is termed cytotoxic hypersensitivity. Okay? And it may affect a variety of organs and tissues. Type 2 and type 3 are nearly the same regarding the antibodies. The antibodies are the same IgM or IgG generated inside the body, but the antigen is different. The difference here relies in the antigen. In case of type 2 hypersensitivity, the antigen may be endogenous, it's part of cell surface, so it is attached to cell, it is part of cell surface, or exogenous, chemical, it's a hapten, which enters into the body and attached to a cell surface also, a cell membrane. So here we have attached antigen, okay? Take care for this one. It is attached antigen, not soluble one, like type 3. It is attached, should be attached to the surface. It is either part of cell surface, endogenous, or exogenous, hapten, which is attached to cell membrane. The antibodies, primary IgM or IgG classes. The lysis here is mediated by the complement or by phagocytes, and the killer cells may also play a role, what's termed antibody-dependent cell cytotoxicity. Lysis of the cell in the presence of antibody, okay? First one is the incompatible blood transfusion. You know, we have ABO and RH. We have 4 types, type A, type B, type AB, and type O. The type A have antigen of A and antibodies against B. Type B have antigens of B and antibodies against A. Okay. Here, if a person of type B donate blood to type A, there will be an intracellular vascular hemolysis, okay, mediated by the complement due to incompatible blood transfusion, and this is type 2 hypersensitivity. Okay, the other one is the RH group. It is extravascular, mediated by the phagocytic cell. We have the erythroblastosis fetalis, and we'll discuss it now, and the autoimmune hemolytic disease, autoantibodies generated against the RBCs leading to its destruction. In erythroblastosis fetalis, we have a husband who is Rh positive, married a wife who is Rh negative. The baby is Rh positive. The first baby usually passed well. However, during delivery, there will be antibodies. There will be passage of the Rh factor, which is Rh positive, to the blood of the mother, where B cell activation occurs with production of IgM and memory cell. Okay. The next subsequent pregnancy, second pregnancy, the passage of or crossing of these antigens through the placenta to the mother will lead to activation of this memory cell to development of plasma cell, which will generate IgG in a huge amount. As you know, IgG can cross the placenta and will attack the fetus, leading to its death. So this is erythroblastosis fetalis. Sometimes the fetus may pass with severe jaundice after delivery. Okay, but it's better to give the mother after the first delivery the anti-Rh antibodies. Okay, this is also type 2 hypersensitivity. We have the white blood cell lysis, like the granulocytopenia, and the platelet destruction, immune thrombocytopenic purpura. As we discussed these examples, you may notice that they are organ specific. There's attacking specific organ or specific tissue in the body, okay? Not a systemic one. The third one is the immune complex hypersensitivity. Immune complex hypersensitivity. The antigen here is soluble and not attached to the organ involved, like type 2, okay? The antibody is IgG or IgM also. What happened here? There is an insoluble immune complex, antigen-antibody complex, mostly of IgG, sometimes IgM is involved. The source of antigen may be exogenous, like chronic bacterial, viral, or parasitic infection, or it may be endogenous, like non-organ specific autoimmune disease. This is our self-antigens, which generates a self-antibody against it, like systemic lupus erythematosus, SLE. This is a systemic autoimmune disease. What happened here? This is a soluble antigen, will lead to activation of B cell, plasma cell, then antibody. Then we have a soluble antigen-antibody complex. The antigen-antibody complex will what? Deposit in the basement membrane of the blood vessel. This will lead to activation of the complement. Then complement 5A is released. Okay. Complement 5A is a chemotactic factor. It will attract the neutrophils to the site of the inflammation. The neutrophil will release lysosomal enzyme, leading to the destruction of the basement membrane of the blood vessel. Okay. Again, once more, another figure. This is the antigen. This is the antibody. Okay, we have immune complex. Immune complex deposit in the basement membrane of the blood vessel. Activates the complement. We have complement 5A, which is a chemoattractant. It will attract the neutrophils. The neutrophils will release what? The lysosomal enzyme, which will destroy the basement membrane of the blood vessel. Okay, this is the mechanism, a simplified way. Let's move to the types. We have ulcer reaction, your case. Ulcer reaction is a localized form. Serum sickness is a generalized and severe form of this disease. We have hypersensitivity pneumonitis. We have post-streptococcal glomerulonephritis, okay, occurs after infection by streptococci, and the autoimmune diseases like rheumatoid arthritis and systemic lupus erythematosus. Serum ulcer reaction is a very rare condition which occurs after vaccination with tetanus or diphtheria. Okay, it is a very, very rare one. Well, it is associated with vasculitis and tissue necrosis. After vaccination, IgG will bind to the antigen, making a complex, deposit in the site of injection. Then C5a is released, leading to what? attraction of neutrophils, release of lysosomal enzyme, and local inflammation, like this. This is the ARSAS reaction. It is a very, very, very rare condition. The fourth type is type 4, which is cell-mediated type, okay, or delayed type. We have here two examples, like tuberculin test, Manto test. Okay, we use it to identify whether the person is sensitized or have been infected or vaccinated by TB or not. Okay. In this part, the lesion is characterized by induration and erythema. The other one is the contact dermatitis which occurs on the skin due to wearing, for example, specific watch or specific clothes for a long time. Okay, but you are allergic to it. So, what is the mechanism of type 4 hypersensitivity? The first one is T cell sensitization on the first exposure. Let's make it a skin allergen. It will penetrate the skin, will be uptaken by Langerhans cell, dendritic cell, migrate to lymph nodes, formation of sensitized T cell, and memory cells is formed. On re-exposure, okay, on repeated contact with the antigen. The T memory cell, T helper cell form, will recognize the antigen on antigen presenting cells. So it will release inflammatory cytokines. The inflammatory cytokines like interferon gamma and tumor necrosis factor alpha will activate the macrophage. Okay, so will lead to phagocytosis of target cell and production of hydrolytic enzymes. Okay, the hydrolytic enzymes will lead to manifestation to appear, which is maximum 48 to 78 hours following re-exposure. The other one is activation also of T cytotoxic cell, which will which will kill the somatic cell, dermal cell, expressing the foreign antigen on its surface by MHC class 1, as you know. Okay, causing direct cell destruction. So in the figure here, we have two forms. We have the pre-exposure, will be activate, the dendritic cell activate T helper cell, sensitized, so we'll have a memory T helper cell. On re-exposure, the memory T helper cell will release cytokine, activating the macrophage to phagocytose the affected cells and also to release the inflammatory mediators. The other one is cytotoxic T cell will also attack the site, okay, directly killing the somatic cell, expressing the foreign antigen on its surface by MHC class 1, leading to the appearance of the lesion. Okay? This is a common question asked by you to me, especially after you will study the autoimmunity. Doctor, systemic lupus, it is a hypersensitivity or autoimmunity? Because it was mentioned as type 3 hypersensitivity, and this is also non-organ specific or systemic autoimmune disease. How it occurs? Systemic lupus erythematosus is what? An autoimmune disease. The autoimmune disease, we have a self-antigen which will generate the antibody. The mechanism of the lesion is by immune complex, and this is the hypersensitivity. Okay, the occurrence of the lesion is by hypersensitivity. In organ specific, like autoimmune hemolytic anemia, it is autoimmune disease. Okay, but the mechanism of the lesion occurs by what? Type 2 hypersensitivity. Autoantibodies directed against the RBCs with the help of activation of the complement will lead to cell lysis. Okay, here autoantibodies are present against self-antigen. They are soluble antigen, so there will be antigen-antibody complex deposition, activation of complement, C5a released, then neutrophils is delivered to the site of the lesion, releasing is what? This damaging lesion. We have type 4, as I mentioned, activated macrophage releasing the mediators, and type 1 cross-linkage of IgE on the surface of the allergen. Now let's move to summary and wrap up. We have 4 types of hypersensitivity. Type 1, we have the allergen, cross-linkage of IgE fixed on the surface of mast cell and basophils leads to release of mediators, okay, like histamine and leukotrienes. Type 2, we have bound antigen or cell surface antigen plus IgM or IgG will lead to complement-mediated lysis of the cell. Type 3, we have a soluble antigen in presence of IgM and IgG will activate the complement. Complement 5A will attract the neutrophils, okay, to what? To release the lysosomal enzyme and destroy the basement membrane of the blood vessel, and this is the immune complex type. Type 4, we have pre-sensitized T cell. The T cells on the first exposure is sensitized, memory cell is formed. On re-exposure, the memory cell, T helper cells will activate the macrophage via cytokines, leading to phagocytosis and release of inflammatory mediators via macrophage. And the last one is T cytotoxic cell also mediate direct cell lysis of target cells like skin test expressing the foreign antigen on its surface via MHC+1. I hope you have enjoyed this lecture. Thank you.